Good morning and welcome to today's webinar, Trauma Informed and Trauma Responsive Care. Today's training is being offered by the Behavioral Health Quality Department and Behavioral Health Medical Directors. Today's training will be led by Dr. Tom Allen and Dr. Brooke Parrish. If you have questions for the presenters, there will be time at the end for questions. Please type your questions in the Q&A box. All right, Allen, take it away.
Good morning, everybody. I'm Dr. Tom Allen. I'm Executive Medical Director at Healthcare Service Corporation, and I'm joined by Dr. Brooke Parrish, who's also an Executive Medical Director of Behavioral Health at Healthcare Service Corporation. I'm a psychiatrist, and Dr. Parrish is a psychiatrist and an internist. So, welcome. Today we're going to talk about trauma-informed and trauma-responsive care. Next slide, please. So here are our disclosures. Next slide. So here's an overview of what we'll discuss today. First, we're going to define trauma, and then we'll talk about some principles and approaches for trauma-informed care. Then we'll talk about how to support a patient with a trauma history, and then look at some screening tools. Next slide, please. So, next slide. So first, on how to define trauma. So the next few slides, we're going to go into that. First, we'll look at a trauma definition, and then we'll look at different trauma types. Then we'll look at trauma responses. Then we'll look at physical manifestations, and then we'll look at emotional and behavioral manifestations. Next slide, please. So here's a definition of trauma. And essentially, we want to define it. We look at the 3 E's, which are events, experiences, and effects. And so essentially, a trauma is an experience that can cause intense physical and psychological stress reactions. But it starts off first as an event, which is typically an event that is life-threatening in nature. And the second part of this is how we experience the event. So, for example, how we interpret it, whether we feel in control or not, whether we have sufficient coping skills, and what kind of external supports do we have. And then finally, this can lead to certain effects. So there could be a physical stress reaction, which we'll get to in a little bit, which is typically the fight or flight response. That's an increase in our sympathetic nervous system. We have increased blood pressure, increased heart rate, increased breathing, tightening of muscles. And then we can also have psychological effects. So those are the emotional responses to the triggers. So that could be difficulty concentrating, worrying, feeling overwhelmed. And sometimes these events cause these reactions, and then the reactions go away. So people can go back to their baseline and live their day-to-day lives. However, if the event is particularly traumatic, or if there are cumulative effects over time, or if somebody doesn't have the sufficient coping skills or social supports, then that can lead to prolonged trauma reaction, which can have lasting effects on the person's functioning, physical, social, emotional, or spiritual well-being. Next slide, please. So I'm going to look at 3 different types of trauma. They're acute, chronic, and complex. And we'll get to the chronic and complex later. But first, I'm going to talk about acute trauma, which is typically a singular event, one event or a sudden event that can disrupt well-being. It can lead to traumatic shock, however, which can cause the physical and psychological symptoms we talked about before, and can be disruptive, but doesn't necessarily persist. It can happen and then go away after the event diminishes. So these are accidents, falls, near drowning experiences, assault or violence, acts of war or terrorism or violence in the community, natural disasters, and emergency medical procedures. And as we said before, that often this can go away, but sometimes it can persist. If you have multiple types of trauma like this over time, or you have repeated instances, that can cause chronic trauma, which can lead to a prolonged stress response, which can have downstream effects, um, significantly interfering with people's ability to interpret the world or manage stress or manage emotions. Um, and this can persist even after the incident has gone away. Next slide, please. So I'm going to talk about the third type of trauma, which is complex trauma. And one example of this is adverse childhood experiences. And I'm going to go into this a little more detail because it's pretty significant, especially when it occurs when our brains are developing, typically between the ages of 1 and 17 years, or is when the majority, a lot of this happens. And this can affect children's development and cause difficulty experiencing the world and coping with stress later in life. So we can see some of the consequences of adverse childhood experience, or ACEs, in adults, because of the nature of the trauma and its occurrence early on in life when the brain is developing. And so this examples can be physical, sexual, and emotional abuse, poverty, racism, discrimination, and oppression, childhood neglect, the loss of a parent or a loved one at any age, exposure to domestic violence. And this is significant because since our caregivers, our parents, are typically responsible for our sense of safety, if we see anything that disrupts that sense of safety, so we worry that one of our parents is potentially unsafe himself or herself, then this could lead to a feeling of lack of safety ourselves. Exposure to parental drug abuse, parental mental illness, and prenatal and perinatal trauma. And often, as children, our parents help us learn how to self-soothe. You know, they're there to soothe us, but also we learn how to do that for ourselves over time. And if we don't have a important parental figure like that who takes on that role, then we don't really develop those skills in ourselves. Um, and and also, we'll get to this later, but without this significant, without this attachment that we have early on, we we have difficulty forming attachments with others later in life. So it can cause relationship problems, um, problems with domestic partners, or problems with people in authority, or problems with working with people in a clinical setting, for example. Next slide. Next slide, please. So here are some trauma responses, and many of you have heard of these already. They're the fight, flight, freeze, and fawn responses. The fight is typically if someone's acting combative, aggressive, reactive, defensive. These are all in response to a stressor. There's a flight response, which is anxiety or having a panic attack, wanting to run away, remove oneself from the situation. There's a freeze response, which is shutting down or feeling numb. And then there's the fawn response, which is becoming people pleasing, overly polite, obedient, avoiding conflict. And the reason that we're bringing these up today is often we see these characteristics in people in our clinical setting. People act often, if they feel stressed or anxious, they may take on one of these ways of acting. And what's helpful, and the main reason we're bringing this presentation to you today is to try to see people through a trauma-informed lens. That instead of asking like, "Gosh, what's wrong with this person?" A more helpful question would be, "Gosh, what happened to this person? What could be behind some of these behaviors?" Um, and I'm going to go a little bit off slide here. I want to talk about some of the neurobiology of the fear response or the stress response and kind of what happens in our brain and the areas that our brain that can help buffer that. And we'll see that people who have significant adverse childhood experiences don't have the ability to buffer that stress response as well as those without those kinds of experiences. So the three main areas of the brain, I'm just going to touch on briefly. Many of you have heard of them. One is the amygdala, which is inside of our brain that is kind of the center for how we experience fear or anxiety. It's our kind of emotional center. And that goes into overdrive when we're stressed. And then we have the hippocampus, which is on the side of our head and our temporal lobe, which helps us with learning and memory. So it helps us to kind of reason through or remember situations, and we can kind of dampen some of these stress responses. And then finally, there's the prefrontal cortex, which is in the front of our head, which is responsible for our thinking and our higher level learning. And this is also what's used to help reason out of emotionally charged situations. And we know with science and studies over time that the degree to which someone has had adverse childhood experiences, it causes the amygdala to go into overdrive, and these dampening parts of the brain, the hippocampus and prefrontal cortex, don't work as well. They lose some of their volume in the brain, and they don't have the neural connections that are necessary. So as a result of this, people kind of are in a heightened state of fear often, and they perceive the world as a potentially dangerous place. So it might lead to some of these responses that we see in the clinical setting. Next slide, please. So what are some manifestations of trauma? In the physical health side, we see higher incidence of COPD or chronic obstructive pulmonary disease in people who have a history of ACEs or childhood trauma. And this is partly due to often people with significant trauma history have difficulty managing their emotions and often turn to substances like alcohol, illicit drugs, or tobacco to manage some of those emotions. And with excessive tobacco use, there's higher risk for COPD. So we kind of see that correlation with people with a trauma history. Chronic pain, certainly, physical, emotional pain is often manifested in physical pain, and it can exacerbate underlying pain disorders. Stroke or cardiovascular issues. So we know that with trauma, there's the heightened sympathetic nervous system drive, increased blood pressure, pulse. This can take its toll on your heart. And it can also lead to things like heart attacks or strokes. Migraines or severe headaches can result, gastrointestinal issues, sleep disturbances, urological problems. So this could be like overactive bladder, or we see in youth like bedwetting at night can be a manifestation of some of the trauma, muscle tension, and also metabolic. As we know, with increased stress, we have increased inflammation, and this can cause damage to our vasculature, which can lead to things like heart disease, strokes, and even dementia later in life. Next slide, please. And some manifestations of trauma in terms of mental health, certainly, if we perceive the world as an unsafe place, this can lead to heightened anxiety, certainly heightened depression. PTSD or post-traumatic stress disorder can result. This is typically manifested by symptoms of, hypervigilance, kind of always looking over your shoulder, re-experiencing, so nightmares and flashbacks, and also a lot of avoidance behaviors, not wanting to go outside or expose yourself to situations that might be re-traumatizing. Certainly severe difficulties in relationships with other people, functioning impairments, social, occupational, academic settings, drug, alcohol, and tobacco use or addiction. And this is what we talked about with, you know, using substances to self-medicate some of those difficult to manage emotions, prescription medication misuse, suicidality, which can be a result of kind of sometimes people feel very empty as a result of repeated trauma, or, especially sexual trauma, or even, combat related trauma, just, not really feeling comfortable in one's own skin, in a lot of ways. Self-harm as a way to kind of modulate these emotions or regulate emotions. Disordered eating, certainly the negative body image, or another way of also modulating emotions through um, certain eating disorders that can develop. And then somatic complaints. Sometimes we see somatoform disorders or other physical symptoms which are exacerbated or caused by underlying psychological distress. So definitely the trauma can take its toll, physically, but also emotionally and behaviorally. Next slide, please. And then finally, just to circle back to substance use, exposure to traumatic events, especially adverse childhood experiences where people don't often develop that internal ability to regulate emotions, can be associated with increased substance use. And not only to manage emotions, but also there's increased incidence of impulsivity that people with these experiences can have more impulsivity or more risk-taking behaviors, and this can play out in substance use disorders. Also the case in people with PTSD symptoms, and then also people with adverse childhood experiences like poverty, um, and increased risk-taking behaviors, as I said, can be a result of excessive trauma, but can also lead to uh, worsening substance use disorders as well. So next slide, please. All right, well, I'm going to pass this over to Dr. Parrish. Thank you.
Thank you so much, Tom. I'm going to talk a little bit about both in terms of for the clinical and the organizational side of trauma-informed care. Next slide, please. So what are the benefits? You're going to make a significant investment if you make the commitment towards trauma-informed care, both with training and with even the physical outlay of your healthcare organization. So why would you want to do this, right? It's a pretty large investment. What are the benefits? One, patient engagement, that if a patient feels safe, they're more likely to return, and therefore you're going to have better health outcomes. They're more compliant if they feel that they're really part of the solution. Both provider and staff wellness. Remember, a lot of the folks that go into the helping professions have trauma of their own. So how do we, in terms of healthcare providers, make sure that we ourselves are safe, our staff is safe, along with the patients? And again, changing that perspective of what's wrong with you to what happened to you. Could imagine that perspective shift really does help promote this wellness within the facility and healthcare. And also you will see decreased utilization. And I would also go back to say for the provider and staff wellness, if they feel safe, you're going to have less staff turnover, and a much more productive workplace. Next slide, please. So trauma-informed care, you have to have both the clinical and the organizational. If just the clinical staff is trained, it's going to basically not work. Sarah Bloom basically said, trying to implement trauma-specific clinical practices without implementing trauma-informed organizational cultural change is like sowing seeds on dry land. Next slide. So what are the core principles behind that trauma-informed approach to healthcare? One is patient empowerment, of really looking at that individual strengths and having them become part of their treatment and helping them reach their own healthcare goals. Instead of looking at doing something to or for a patient, but having them doing it with a patient. Choice, again, very much in terms of what we consider informed consent. Um, Informing patients regarding all treatment options and so they can choose, knowing the risks, benefits, indications, and other choices, including doing nothing often. Um, Collaboration, again, maximizing the collaboration, not just with the patients, but also among all that healthcare staff, so that no one's really operating in these silos and feeling isolated, but realizes they have the health or the help around them, that families and using those support systems, both as using that healthcare organization facility as its own social structure support, both for the patient and for the staff. And again, safety, making sure that your healthcare facility and organization is a safe place, that both their physical and their emotional needs are met and that they feel safe. And again, trustworthiness, really creating clear expectations with patients, what can be done, what can't be done, um, and what exactly those proposed treatments entail. Again, really having that informed consent and having that education of, especially for healthcare procedures, which can be very traumatizing, and the feeling that that power is taking away, but having them know exactly what is going on and informing them each step of the way. Who's providing the services and exactly how that's going to be done. Next slide, please. So looking at the organizational, really it's leading and communicating about this transformational process. You would also want to engage patients in terms of that organizational planning and process, and really training the clinical along with the non-clinical staff members. So this is one thing I really like to emphasize, because it's not just the clinical staff that's going to create that safe space, but even really more importantly, the people that the patients talk to on the phone, the receptionist, even down to those that do checkout, etc. Again, creating a safe environment, making sure that they feel safe in the waiting room, making sure that they feel safe in the exam room, and that they really do not have any extra stress put on within that environment. And again, preventing second traumatic stress in your staff. Remember, those healthcare professionals, so many of us do tend to have that trauma history. And then also hiring a trauma-informed workforce. Does that mean that you necessarily have to go out and say, before we hire you, you have to take XYZ courses? But really looking at those that you hire in terms of looking at their behavior in the past. Are they calm? Are they caring? How have they reacted in the past? And it may not necessarily be that they've had that healthcare experience, but you're looking at if they're in retail, have they been calm, helpful, etc., and interviewing for finding out such practices. Next slide, please. So in terms of clinical, how do we do this? And Tom is going to talk in a little bit about a little more of the nuts and bolts of how to put this together. This is more the 10,000 foot view, but really involving patients in the treatment process. A lot of experts actually consider using them as consultants and reimbursing them for such in terms of really looking at how do they feel in terms of the waiting room? What would make them feel safer? Taking them through a typical visit, what would make them feel safer? Again, screening for trauma. I'm going to talk a little bit more about this. And there is a little bit of probably differences of how you want to screen for trauma depending on your practice. And we'll talk a little bit more about those nuts and bolts coming up. Again, training staff in very trauma-specific treatment approaches. And again, I'm going to talk a little bit more about that. And it's going to make a difference of whether you're a primary care doc or whether you're in behavioral health. And again, engaging the referral sources, the behavioral health, and partnering with different organizations that are also trauma informed that you can refer your patients to if you need further assistance for them. Next slide, please. And again, the patient experiences. So many of our patients are coming in with a history of trauma. It has often been referred to as a public health crisis. That is often sort of unspoken, but realizing that that experience is going to make that difference between whether they are compliant, come back, or even come back at all. And realize that that patient's experience due to adverse childhood experience or even trauma as an adult, make it very difficult as an individual in terms of anything that they feel is invasive at all. So vulnerability in physical positions, that you're doing something to them as opposed to actually making sure that they really have consented to it. And it really doesn't take that much more time of informing them. I would like to listen to your heart and lungs. Do you mind if I move your piece of clothing this way, or letting them either do it or consenting to it. And again, that physical touch for somebody that has had significant physical trauma, again, making sure that they are aware of what is going to happen. Certainly there's fears of what's going to happen to them during surgery, surgical mistakes, or again, receiving a bad diagnosis or bad prognosis. And again, sort of that collective reaction to a traumatic event. And as I said, it's sort of a public health crisis in terms of this entire society and group. And one can argue that in the past couple of years, a lot of us have had very traumatic experiences, especially with the pandemic. And I think one of the silver linings is that it has allowed us to talk a little bit more about even past traumas beyond what happened within the pandemic. Next slide, please. Next, I'm going to turn it back over to Tom for a little bit more of those nuts and bolts.
Thank you, Brooke. Next slide, please. So here are some tips for creating a safe healthcare environment for patients and staff. And we'll focus first on the physical environment. So just looking at the right of this slide at the top, just some suggestions. Keeping parking lots or common areas, bathrooms, and entrances and exits well lighted. Decorate with warm colors and artwork, and create spaces for staff to relax. And this is important not only for our patients, but obviously for our own staff, especially if they're at risk for secondary trauma, and really need to have that camaraderie of others or that time away so that they can kind of work through some of the emotions they might experience. Ensure security guards are readily available in settings where necessary. Consider stationing them at building entrances and exits to monitor the flow of traffic in and out of the building. So this will help people feel safe. Keep noise levels in the waiting rooms low. Use positive and welcoming language on waiting room signage. And then finally, ensure people are not allowed to loiter or congregate outside entrances and exits. Um, just think of a lot of people with trauma history have um, they can often have a hyper startling response, or they get quickly thrown off if something is outside of a predictable or um, kind of consistent format. So making sure that people are known in advance of things, as Dr. Parrish said, that there's consistency, that there's uh, a limited amount of variables in terms of not only instructions, but also stimuli and other things that can come into their physical space. Next slide, please. And here are some tips for creating a safe healthcare environment for patients and staff, looking at the social and emotional environment. Um, so train all clinical and non-clinical staff to communicate effectively with patients. And this is, as I said before, or as Dr. Parrish said, emphasizing patient choice and autonomy is so important, that they feel in control and a part of the process. But also, since people with trauma often have difficulty processing, they might have difficulty focusing, especially if they're inundated with certain emotions. Making sure you speak clearly, easy to understand format, speak with consistency and instructions, for example. Um, but also try not to use language that's potentially hurtful or shameful, or anything that can re-traumatize the person. Encourage frontline staff, including front desk staff and security guards, to greet patients in a warm and welcoming manner. Understand how an individual's culture affects how they perceive trauma, safety, and privacy. So be curious about how some of their cultural norms or backgrounds can affect their preferences or how they see things. Send medical forms that require patients to provide sensitive information ahead of time so that they're not taken by surprise. Ask patients whether they are comfortable with having the door shut during exams or meetings. Again, the autonomy or personal choice. And then keep consistent schedules and offer sufficient notice and preparation when changes are necessary. Next slide. And I will hand this back to you, Brooke.
Thank you for those helpful tips. Next slide, please. So we're going to talk a little bit about trauma screening. There's a little bit of a debate on whether we should do universal screening versus more focused screening. And it kind of depends on your practice situation. For primary care, it is often argued that early universal screening is done. One, this eliminates bias. And two, also in terms of doing it early, in terms of the relationship, you already know the aspects of trauma that that person has. While if your behavioral health, that you may want to do more targeted and in-depth. And with the universal screening, often we're going to talk about some of these screening instruments that are self-report, that they don't have to talk further about them. And that will be part of the patient choice of whether they want to. You also don't want to do the screening that often. Certainly, this is one of those things that you could almost consider one and done, and then just check in if anything else happened every so periodically. Certainly, in terms of the screening, you do not want to re-traumatize a person, and certainly for primary care, doing some of the more in-depth assessments may be better left to that behavioral health clinician. Nevertheless, it is so important to gather those past experiences because, as we have talked about, that will have so much of an impact on the physical health. And certainly, as we're going to chat even more about in terms of the substance use disorder and how much trauma and substance use disorder are connected. And once those decisions are made, you're starting to look at the long-term effects of chronic disease in terms of liver, lungs, and even heart, diabetes, etc., be it whatever that substance use, be it food, nicotine, alcohol, or other. The other thing I would like to emphasize is that we know anxiety, mood disorders, and substance use disorders are all connected to a higher risk of suicidal thoughts and actions. So it is important to also screen for suicidal thoughts and actions. And there's screening tools for that as well. Or if you are comfortable, merely asking, have you ever had thoughts of harming or killing yourself? One of the most popular of the screening tools is the Columbia screening. And this is something that can be done, and it does not necessarily even have to be done by the provider themselves, but can actually be done with trained frontline staff. Next slide, please. Screening tools. There we go. So in terms of screening tools, there are several, and a lot of these can be done via self-report. Like the Stressful Life Experiences is 13 hours, or 13, not 13 hours, thank goodness, items. And it really looks at both the stressfulness of that situation, of the 13 that they have out, along with the interpretation. And so examples of questions would be, was physical force or a weapon ever used against you? And then did anyone die from that? Was there harm, etc.? The SPAN is really looking at more of the stress symptoms based on the trauma and what the patient would identify of those symptoms the most distressing. The primary care post-traumatic stress disorder screening is a 5-question, and it's very quick and easy and presents the impact for traumatic experience. PTSD checklist is again looking really at a lot of the symptoms of the PTSD. Life event checklist, and all of these, I believe, I know most of these, the life events checklist is based on the DSM-5, is completely free. You can download it at any time you want. And it is a 17-question checklist. And again, the ACEs, which is one of the reasons that folks started looking at trauma-informed care, was when the ACEs came out and we realized how much impact those adverse childhood experiences did have on the physical health of adults. So the ACEs, one could consider, is the OG of the screening tools, arguably in terms of trauma-informed care. It is a 10-question screening tool. And then there's also the brief trauma questionnaire, which is a 10-question self-report. Next slide. And I will say all of those are for validated for adults. For children, up to age 19 is the pediatric ACEs and related life event screener, and the pediatric trauma stress screenings tool. Also for children looking at depressive or somatic symptoms, PHQ-9A is the A standing for adolescents, 11 to 17 children. So it's pretty much the analog to the PHQ-9 for adults. And then, of course, the somatic symptoms for parents or guardians. Next slide, please. So in terms of psychotherapy, there are a lot of different models. Most of them are based in sort of cognitive behavioral therapy. Cognitive behavioral therapy is a large umbrella of which there are various and sundry treatment models under it. Some of those maybe include like seeking safety, which includes integrating the substance use disorder, and focuses on skill building, along with like prolonged exposure therapy, which is really focusing on sort of breathing exercises and real world practice of dealing with the trauma and things that come up. In terms of prolonged exposure therapy, it's typically a 8 to 15 session model, and outcomes have basically shown a 86% improvement over controls. Cognitive processing therapy, arguably also under the cognitive behavioral therapy, but again, sort of changes those beliefs about a trauma and getting a new understanding of it. EMDR, there are multiple different iterations, some of it using eye movements, tapping, tones, eye movements. And again, this is the therapy that looking at those memories and using that bilateral stimulation, be it the tapping, tones, or eye movements, connecting both the emotion and logic surrounding the trauma. This is endorsed by both the World Health Organization and the Veterans Affairs Administration. And it was one that was hoped to be perhaps close to a panacea. It does have good results. Unfortunately, meta-analysis has not shown it to be superior to other um, forms of um, similar psychotherapy. Certainly, a lot of folks will also look at alternative treatment potentials. And again, this can be used in conjunction with either medication or traditional psychotherapy and include acupuncture, yoga, transcendental meditation, along with even just mindfulness. And again, one can argue even mindfulness would go under the cognitive behavioral umbrella. Next slide. So some medications, certainly a lot of the SSRIs and SNRIs can be very helpful. Some people will choose to take medication, others will not. Prazosin, which goes by the brand name of Minipress, is helpful for nightmares. It is a alpha blocker. The other alpha blocker that is well known is clonidine. Unfortunately, studies with clonidine have not shown it to be nearly as helpful for unknown reasons. Next slide. And again, we've talked a little bit about PTSD and substance use disorders and how those are connected. And again, how we already know how much those substance use disorders are connected to our overall physical health and how those can connect themselves to lifestyle in and of itself that causes sort of that tailspin in physical health. So I'm hoping that you can see sort of how those linkages are coming together with trauma, substance use disorder, and physical health, and why treating the trauma and making sure that your healthcare facility and staff are trauma informed to create that welcoming environment really can help in terms of that holistic health of that person and helping them reach their health goals. Those PTSD certainly have a much higher rate of substance use disorders. And I'm using the term substance use disorders fairly loosely here to actually include almost any of the addiction disorders that we can look at, including like binge eating. And I would put in all eating disorders they are at higher risk for. And again, any of the other addiction disorders, you can certainly find much higher risk for those that have experienced traumas. We also know that trauma has a dose effect. The more trauma, the higher the risk. So it is a very much dose effect. And that there are theories that those that have substance use disorders are sort of self-dosing, and that can be any of those addictive disorders, be it gambling, gaming, internet, etc. Food, etc., are being used to alleviate or those PTSD symptoms by self-dosing. And certainly research has shown that really taking an all-in approach and addressing everything in terms of both substance use and the trauma, and using psychotherapy and medication, and if you wish, some of the alternative medication or alternative treatments as well, can really help with both the trauma and the substance use disorder. And I do believe there has been a bit of a change. When I was in training, back when the dinosaurs roamed the earth, I was really taught that went after the substance use disorder first, and then you could deal with the trauma. But I really think that research is showing you deal with them both at the same time. Next slide, please. Here are some extra resources for you. You can see both American Psychological Association has a lot of information for you, the National Library of Medicine also, and SAMHSA as well. Next slide, please. And here are, you will be able to get these slides. Here are some QRS codes where you can share with your patients that are trauma informed of how to help themselves in terms of getting help for substance use and mental health. Next slide. Any questions?
All right, we will open it up right now. We'll be watching the chat. If you have any questions for Dr. Parrish and Dr. Allen, now is the time. Thank you, Dr. Parrish and Dr. Allen, for the wonderful webinar this morning so far. And in the meantime, while we're watching this, I did want to put out a reminder that you will receive an email link to complete an evaluation and attestation for the CME CEU credit after 24 hours of today's webinar. If you'd like a copy of the slide deck, you can also download a copy at the same site you received your CME and CEU credit. I'm not seeing any questions come in. Team, are you seeing others? I mean, it just says that you all covered all the important pieces, Dr. Allen and Dr. Parrish. All right, well, with that, I just want to thank you all again for attending today, and I hope you all have a good morning.
Thank you. Have a good morning.
Thank you.
Thank you. All right.
Thank you.
Thank you.
Bye.
Bye-bye.